Thank you. It's such a pleasure to be here with my colleague. And this is fully intended to be a conversation. We put together some questions into some background slides, but we want is a discussion. So if we get through 3 of our slides, that's great. If we get through all of our slides, fantastic as well, but I think we have enough time to have questions. And also, well, I know we have time to have questions. Our job, or our intent is not to say transplant is better, or gene therapy is better, or you should do this or that. Our goal is to answer questions and provide clarity when we can, and acknowledge the uncertainties where they exist. So what we thought we would do, and again, we know very well educated audience about this, but try to level set about what are the treatment options for early cerebral ALD. Also with the caveat that we are pediatric transplanters and don't have as much experience about transplanting adult patients with cerebral ALD. So when we think about stem cell transplant and cellular therapies, and when we talk about cellular therapies, we're generally thinking about gene therapy or allogeneic transplant. And what allogeneic transplant means is you're getting your cells from another person. And so we think about the different categories and sort of what's involved in that process of it. And so for a stem cell transplant, you need to find a donor. You're getting healthy cells or stem cells from someone who doesn't have ALD. And when we talk about what a stem cell is, we mean the cells that are growing inside your bones that can turn into the cells that make blood, the cells that make platelets, the cells that make your immune system. And one of the things I think that we all do when we're talking to trainees or friends or family about this is one of the questions is why on earth would this work for a neurologic disorder? And the reason is that those stem cells, those baby cells, or the reason we think, those stem cells, those baby cells can migrate and develop into cells that can help differentiate or change over time and mature into cells that can stabilize the disease and stop disease progression. And so stem cell transplant, using another person, you've got to find a donor. And that could be someone in your family, that could be someone somewhere in the world, that could be cells from an umbilical cord, it could come from lots of different places. And then, so when we talk about auto, those are cells coming from yourself. So a key differentiating factor for for gene therapy versus allo transplant is that with the auto transplant or gene therapy, you're using your own cells. For the allo, you're getting cells from someone else. And when you're getting them from someone else, they can come from bone marrow, so we stick needles in the hip bones to try and get that. It can come from peripheral blood, which is the blood that's circulating around in our system that we've given you meds to try and get that out. Or it can come from the cord blood that is saved from people either in private banks or public banks. And as an aside, we know that there were some questions coming into the talk about cord blood banking, and we'll certainly find time to talk about that. For both of these things, you need to do preparation, and that is to get rid of the cells, those stem cells inside the bones, so that you can accept the new cells coming in and that your immune system doesn't kick them out. For gene therapy, where you're using your own cells, you've got to get rid of them, literally as low tech as it sounds, it's actually true, to make space for the new cells coming in. Something we talk about a lot in stem cell transplant is this thing called graft versus host disease, or GVHD. And what that is, there's a new cells coming from another person looking at your body as someplace it's not supposed to be and causing inflammation and trying to get rid of it as the way you would a virus or something else. Conditioning or chemotherapy, this preparation, it's required for both gene therapy and allotransplant. There's slightly different ways to do it. And graft versus host disease is not a risk with gene therapy because you're using your own cells. And so there's one of the key differences. I won't talk the whole time, I promise. So just for other visual learners, so our goal, allotransplant and gene therapy, we have the same goal, trying to stabilize disease progression. So allotransplant, your donor's another person, you get chemotherapy. When we say myeloablative, it means it's wiping out all the cells inside that bone marrow. You get chemo, the cells go infused, and they hopefully engraft, which means they take hold in your bones, start to develop and divide, and they differentiate or mature into cells that are microglial cells that express the ALD protein. Gene therapy, we want to get there the same spot. So, but the patient's your own donor. We collect your cells, send them to a lab. An ALD gene is put into those cells, and then basically you go through that same process. Do you want to do the next one? Okay. So shared features, both required chemotherapy. Both can stop the brain inflammation, and the best results for both of them are when it happen early in the stage of disease. So we've said this, key differences, no GVHD risk with gene therapy. You use your own cells, but there is, and this is critically important, a cancer risk from the gene insertion. And that's something we'll spend time talking about. And then for allotransplant, donor cells are used. You do have that graft versus host disease risk. There are complications of immune risk, so infections, other things, and you need to find a donor. We can pause. So we can pause here and see, sorry, we're gonna keep you hopping with the microphone, I apologize. If there are questions about this sort of the foundational piece or not, there don't have to be. Okay. All right, cool, great. So this is always a really important question. Do you want to do this one? Sure. I'm going to pass over to my friend.
Okay. So hi, thank you. So yes, we always get asked who's the best donor for an allogeneic transplant, and I think the answer depends to some extent for what disease we're doing the transplant. But in general, the best donor that we would like to have is an HLA identical sibling, meaning that they share the same HLA. HLA is special antigens on the cells, and this make the body recognize as self or not self. So if the body sees the same antigens, we're all good, less side effects. But we want a healthy matched sibling. The alternative is to find a phenotypic match, meaning the antigens look the same, but they're not inherited in the same way, from the donor registry. The unrelated donor registry, and here we will introduce the National Marrow Donor Program, is the registry of the US where unrelated donors volunteer. They have had some tests, they're registered, and when needed, they get contacted and we start the process. Also, through that registry, we do have access to international registries also. So when we're looking at the registry of the donors, we don't necessarily look at US only, we expand it. And we have more experience with some countries than others, but in general, it's a bigger population, it's more international. Another alternative that has become more common is a haploidentical donor, meaning this is a half match. It's usually a mother or a father, or it could be a half match sib that has half of the antigens of the patient. Where it gets a little tricky here for the ALD is we want a healthy half sib, not necessarily or the parent, one carrier. And then finally, it's umbilical cord blood. This is an unrelated donor in most cases, and this is blood that has been collected from healthy newborns, has been tested and is stored, and we have a lot of information about it, and we can get it at any point. So our choices among those donors depend on what the disease is and how quickly we need to move for the transplant. Any questions so far? No.
I know, I'm just going to quickly, I know that there was a question from a family who was not able to attend in person today, but we had a question about private cord blood banking versus public cord blood banking. And so there is not a right or a wrong answer to that. The right answer is the one that matters to your family or how you approach. So if you are pregnant and are going to have a child, you have the option of donating the cord blood. So the baby is born, baby is over here, cord blood is over here. This is not happening or delaying any health to the baby. And the cord is cleaned, and a needle is taken and extracts the umbilical cord blood. And that can be sent to a private bank for use by your family or someone in your family, or that can be sent to a public bank where it can be used for someone who needs to have a stem cell transplant basically anywhere in the world. If you're donating to a public bank, that is free. It can't always be done at every single center where you are delivering the child. It can be done at many. If you are donating to a private bank, that cannot be used And one distinction about that, if you're donating to a public bank and your family needs that cord at some point, it's not necessarily going to have been held for your use. For a private bank, you are sent generally a kit that you take to the delivery room with you, and that kit you hand to the obstetrician. I have seen people get kits the day before they deliver. I've seen people get them as soon as they know they're pregnant, lots of different ways to do this, and the obstetrician collects, and that is sent to the cord blood center that you've chosen. That cord blood cannot be used for anyone else. Because the cord blood is there, it doesn't necessarily mean you're ever going to use it. Most of the time you're not. It doesn't mean that the cord blood will match any of the siblings. There's a 25% chance of each of them matching if both parents are biologically the same for those children. And there is a cost to that storage. But when we say most of them will not get used, there is a distinction for people who have genetic disorders where that risk of it getting used is likely higher, because there is a chance if you have a child who does not have an ALD, who has a sibling who has ALD, you may end up actually using that. We don't know. And so I think my advice, and I would love to hear, we don't necessarily have the same opinions about everything, is that if you are looking at saving your child's cord blood for potential use, really do some investigation into the cord blood companies. Not all of them are the same. There are certain standards that are held across all of them. And so what I would say is look for one of them that is certified. So there are certain certifications that are for all the public banks. They all have to meet certain standards. Some of the private banks opt in to do that as well, and I would do that. I would also look at one that's been around for a long time, because I think that longevity matters. Probably about 10 years ago or even more, a lot of cord blood banks came up and some of them went out of business and those cords were lost. So look at one that has longevity and experience. And I do know that there is at least one cord blood company that will save a cord blood for free if the child who's being born has a sibling who has a potentially transplantable disease in the future. They don't necessarily have to be transplanted now, they don't have to ever do it. But that is an option for families. So that's just one thing to say about cord blood. Maybe you want to?
No, I agree. Saving the cord blood of a sibling is an indication if somebody in the family has a disease that can be transplantable. One note, the patient's own cord blood cannot be used, right? Because that cord blood has the same disease as the patient. So if, without knowing, we save the cord blood from a patient with ALD, that cord blood cannot be used unless somebody tells us we have special gene therapy we can do on it. It cannot be used as is for transplant. It's not healthy cells.
And sorry, just one last thing about that as well, is that just because they collect the cord blood, it doesn't necessarily mean there are enough cells in there to use. Obstetricians have lots of different experience. Some collect all the time and get lots of cells, some don't. So it's possible that if you saved the cord blood, the child who donated may also need to give marrow and give the cord together, but the expectation is that you would take less marrow than you would if you just had, if you didn't have the cord blood. Okay. The next question is who could get Skysona? Skysona is the gene therapy product that is made by Genetics, which is formerly Bluebird Bio, for those who are familiar with that name, and what is approved by the FDA. The reason we brought this up is since the last time we all met, the FDA approval or label has changed for Skysona. And so right now, the FDA approved indication, sorry for the fireworks there, is that it is approved for children who have early active cerebral ALD, which is typically measured as a less score between 0.5 and 9 with gadolinium contrast enhancement. The patient's age has to be between 4 and 17 years old. I think there could be argument made for older, but it'd be complicated, and now that it's not on study, it becomes actually, unfortunately, an insurance issue as well. And you have to have minimal or no neurologic deficits. We didn't talk much about the neurologic function scale score, but it has to be 0 or 1. And so treatment has to occur early. The thing that changed since last time we met is that previously the FDA didn't say anything about what kind of match the patient possibly has. So what they have said in the past year is that this is you are only eligible to get this per the label, if you have no match in your family, no full match in your family, or no appropriate match in the registry. And so that is actually a very big change since the last time that we met. And the reason that change occurred is because of many of you have heard there is a risk of hematologic or blood cancer with that product. And so it is still available, the product is still on the market, it's just who can get it can change. And there are also questions about what does know about the matching for an unrelated donor, because you may have someone who matches with a blood type, but for some reason is not an appropriate optimal donor, and then I think we'd have the option of having questions, having a conversation with the FDA or the insurance company for that matter. You will hear a lot more about the gene therapy product later this afternoon from Dr. Prasad. Okay. All right. Either way. Go ahead. Okay. So just leading into that, what is the cancer risk with Skysona? And you will see more, I believe, data this afternoon. Okay. So we won't spend too much time on this. So I think it's important when we talk about the cancer risk also to show the positive sides about these products, about gene therapy, and always to show the balance between the positives and negatives. So this is data that came from a publication that included many people in this room, is led by Dr. Eichler and myself, looking at the overall survival and major survival-free of major functional disabilities for gene therapy. So the data that is here included 67 patients who were treated on the study. And if you look, that red line showing how well you do over the top with overall survival is excellent, close to 100%. The major functional disability level is still very good, but a little bit lower. So people had some change in their ALD symptoms. But the real problem is that 10 out of 67 boys treated across 2 different studies have developed a very specific type of blood cancer. And that's something called, well, 2 actually, myelodysplastic syndrome, or AML. AML is a frank aggressive leukemia. MDS is a cancer, but we tend to think of it more almost as a pre-cancer that can, over time, develop into leukemia. What's really tricky about that is we don't know how fast it will progress. In some people, it can stick around for a long time without progressing to AML, and other people it progresses very rapidly. It's highly unpredictable. And so because of that, the recommended treatment for MDS and AML in this case is exactly what we tried to avoid in the first place, and that is getting a bone marrow transplant from another person. If you have leukemia, that AML thing, not MDS, you actually have to get chemotherapy and then get a bone marrow transplant. And that treatment needs to happen quickly. So there have been 10 boys, as I've mentioned, who have developed either MDS or AML. I believe 8 of them had MDS and 2 of them, had AML. There were differences, and you can see in the curves that ALD 104, that was the second study that was done. The first study that was done has a lower risk for reasons we're still trying to understand. We have some theories, but we're still trying to understand that risk. 9 of those 10 patients are alive. 1 of those patients died of complications of the allogeneic transplant. So very sobering information. So that is the cancer risk. I think maybe we'll just go through these slides and then pass this over. So the next question is there a cancer risk after allo transplants? We've talked about the cancer risk after gene therapy. The answer is yes, but it is small. It is a much smaller risk than we would expect to see with the gene therapy. And the reason is, so up here in this corner, chemotherapy, the way we're doing it now, we're learning all the time, is not really smart. It affects the cells that you want to get rid of. It also affects some of the good cells. And so when you do that, you can damage the DNA, and then over time, you can get the cell that has damaged DNA, and that expands. And then over time, you can have this increased risk of developing cancer. And that can happen anytime, and that could be starting very early in the first few years up to even much longer lifetime risk. And so when you look at data, and the data are not perfect, whoopsies, sorry about that, that risk is this estimated lifetime risk of between 5 and 10% over a lifetime. As you get into adulthood, it's a little trickier because adults get cancer for other reasons, but that risk exists. So if you try to look at the numbers, 10 out of 67 in a relatively short period of time, or 5 to 10% chance risk over a lifetime. I'll give you this one. Okay.
No, you go ahead.
Oh, keep going? Okay. So are there other differences in risks besides the cancer? Yeah, and I do tend to think about this as a scale, and sometimes when I talk to my patients and families, some of whom are here and some of whom I think are online, I often think about allo transplant. You've got this scale, and you've got GVHD on it. You've got this risk of trying to find a donor. You have immune suppression. You have a longer time not going to school. You've got all of these rocks here. And then on the gene therapy side, you've got this one big rock. And for every family, that way, and the way the scales tip, it's an independent thing. There are families who are much more afraid of graft versus host disease or not having a donor, and there are families who are more afraid of the cancer risk, and that's okay. And so I think we work together to try to figure out what is right for an individual person and family. So allotransplant, we talked about GVHD a little bit. This is immune attacking the organs. It can attack your skin, your liver, your lungs, lots of places, and that could be very mild, where you put creams on the skin, or it can be life-threatening itself. You tend to get more chemotherapy, this myeloablative chemotherapy, when you're getting an allotransplant, so the risks up front of the process are a little bit harder, so you're at risk for infections and other things. That other side, this big risk, the thing we care about the most, is that risk of cancer. You still get chemotherapy, it's less chemotherapy than when you get the others, and there's been some reports where it takes a little bit longer for your platelets to recover. But again, the way I tend to think about lots of stacking on risks in the allotransplant, and there's one big risk that we think about in gene therapy. I'll do this one.
Okay. So how do we find matches, or how do we find donors in general? We talked earlier about the National Marrow Donor Program. This is the registry. Now, the way that we look for donors and the way that we try to match depends a lot on something that called HLA, and therefore ethnicity of the patient. So different ethnic backgrounds have different chances of finding donors. Why? Because the majority of the donors in the National Registry are white, they are Caucasian. This is how it is. They've reached out to a lot of different populations, but it seems that the highest percentage right now are white. So if somebody is Caucasian, their chances are up to 80% we will find a donor. That is just finding a donor, doesn't mean doing the transplant. However, as we look at different ethnicities, the chances can decrease, and the lowest is always the Black African Americans. There is a fewer percentage of donors in the unrelated pool that are African Americans, and they also have a very large diversity of their HLA. So they have an inherited, if you want, difficulty in matching them, as well as lower numbers of donors. So we have a way to estimate quickly if we're going to find a donor or not, and we run these searches to identify, and then we would know quickly. Now, a little bit more information. The unrelated donor registry right now has about 90 million people in the US. But again, the majority of them are Caucasian. So you understand why it's much easier to find somebody who has the Caucasian race and the same HLA. When we get into other ethnicities, it gets a little more complicated, but again, waiting and waiting is not always the answer, because this is not going to change. So as transplanters for any disease, we know that if we don't get enough answers by our preliminary search, we have to look at other options. And these other options could be the haploidentical, the family donors that are not complete match, but could be used under certain treatments, or the umbilical cord blood. Now, there has been, this goes again, the same information. There is a difference in finding donors. And again, finding the donor from doing the transplant is a little bit more tricky, because find the donor means you go into the registry, you identify somebody. Then they have to contact that somebody, do some tests, and be available for the transplant. So there's a time element and an availability element. But even finding the donor sometimes is a trick. Well, otherwise, we look at other options, and we look at other options quickly. So we evaluate haplo and we evaluate cord blood and see what the options are there for the patient. And sometimes we do that simultaneously, so we don't lose time. Now, because we're talking about ALD, I just had to say that cord blood transplants have a track record for ALD, for metabolic diseases. Even from many years ago when we started cord blood transplants, because they're easily accessible and because these patients cannot wait for months and months, there have been good data. Some of us here in the audience have done a lot of these transplants, and we have good results. So we kind of know how that is going to go. The haploidentical donors are fairly recent because we have developed ways that we can work with these cells so they don't cause a lot of graft versus host disease. So the results are a little bit more recent. I can't say we have a lot of track record, but we have some good preliminary results. So these are options for the patient. Another element that I didn't get into is the age of the donor. So we know very well from transplants in many different diseases that the younger the donor, the better the results. That has to do with biology of the stem cells, it has to do with biology of the donor, but the idea is that having a 50-year-old donor, although that person might be the healthiest person in the world, is not the same as having a 20-year-old donor. And we would always go for the younger donors because we know that the results are better. So it's not just finding a donor, it's finding a donor that is appropriate for our patient, age-wise and other characteristics, and within the timeline that we need them. One way to expand donor access, and that's why we have a slide here, is, and has been discussed a lot, is doing donor drives. The directed donor drives are an effort to call into the community, sensitize them to the problem, make them understand that lack of donors and lack of treatment is not just a family issue, it's a community issue. We have to get them to understand the problem. And people tend to become more sensitive and hear more if there's a person they know, right? It becomes an example. And this is a very good way to mobilize people to get into their understanding of what needs to be done. And we need more donors, and we need more young donors. There are two issues with this. One is that if we didn't find them in 9 million and in a few other million around the world, what are the chances that a few more donors would help? That we can say that it depends how you do the drive, and sometimes very focused, very targeted drives might tap into a population that is specific. The other element is time. So these drives are very good, but it takes a lot of time to collect all the results, to analyze them, and have these people join the registry. So if we do it for somebody who needs a transplant in the next month or two, this usually is not enough time to have an effect from the drive. It will be very good for the next patients, but it will not help the patient in our hands. So this is a wonderful opportunity to improve donor access, to get out to the community, to mobilize people, to understand how important it is and how easy it is to become a donor, to do your mouth and just get a test. But on the other hand, the imminent results on the patient that we have are probably not going to happen. It's going to be a long-term issue. Now, for ALD, sometimes we have a couple of months, sometimes we have 3 months. If we get to the leukemias after the gene therapy, we don't have time. This is not something to wait and see and explain, because there we run the risk of making the disease worse, needing more chemotherapy and needing more toxicity. So it depends where we are and how we position these drives. It is very good for donors. It is very good for the community. Will it benefit our own patient is unclear.
I think this is really just our summarizing slide. So we hope you never need to have this conversation with us. We are open to always having it, but hope you never need to. If you want to have HLA typing done, just to know if there's someone in your family, that's an option, even if you don't need it right now. But if you do need it, there are wonderful transplanters all over the country who can treat you. And we know these are difficult outcomes. These are incredibly challenging situations with intense therapies and lots of considerations that must be balanced. And one of those right in the middle is the family and the patient and what your preferences are and what sits best with your family. And I think my non-medical advice is to always trust your gut in those things. That is the end of our presentation. If you have questions, we'd love to have those if they're ready in the chat. Otherwise, we're also both going to be around here during lunchtime and could certainly have conversations. I see a question already.
My question is, who is not, is everybody told when they're having a baby, they can donate their cord blood?
People know that they can donate the cord blood. Whether everybody knows, I'm not sure. The issue is that we don't have many sites of donation, so you cannot donate in every hospital. That is a problem. Why is that the case? Because to donate cord blood and save it as a graft for transplant is a tedious procedure regulated by the FDA, so you have to have certain controls and mechanisms in place. So it's not available everywhere. However, we can certainly have more disseminated information about that, but it is not available everywhere. So many times families will call and say, I'm delivering in an XYZ hospital. They don't have a donation program. There's not much we can do about that.
Okay, well, Morristown does in New Jersey, and
Yes, they do.
not everybody is being told that
Right.
you can do that. So maybe I could speak to somebody there and make sure they're all aware that
That
you
would
can
be great.
donate.
Yes, I think it takes all voices, like we all have to do those things. I think it's
Right.
pretty hard to deliver a baby right now and not know that you can private bank, but I don't think that, because I think when you go into a lot of obstetricians' offices, that information is everywhere, but public banking, not the same. And so I think that gathering voices, expanding information is always helpful.
Right.
Thank you. Yes. Here, have it. Sure. Oh, sorry. Over here, then. Go ahead.
You mentioned there was a free program for the sibling banking. For those of you who don't know, it's called ViaCord. We did it for our family when my daughter was born. We used that. It's a pretty good process. They'll bring the kit and everything to you. So if you want to know more about it, let me know. Happy to talk about it throughout the conference. My question was on one of the slides. On the cord blood, it said that it didn't have to be an exact match. Can you talk more about that?
Sure. So for different sources, there's a higher risk or a lower risk of graft versus host disease. Because the immune cells in the umbilical cord are so naive, they are brand new, you can tolerate mismatching more than you can with other sources. And so that's one of the reasons that cord bloods were used originally, is to try to expand the number of people who could get good transplants from them. So you don't have to be a perfect match. You don't have to be a perfect match for bone marrow or other stems, peripheral blood, but it's tolerated better from a cord.
What about cord blood or cord tissue?
It's a good question, because I know there's always a question about whether you should donate cord tissue or not. I don't know of a practical use for cord tissue yet. Doesn't mean there won't be in the future, but there's not one that we know of yet.
So through ViaCord, they
Yeah.
give that option, and so we did that
Yeah.
too.
Yeah.
However, to note that most of the transplants in metabolic diseases have happened with donated cord blood units. There will be some, and there have been some from private banks, but the vast majority of the transplants, so the data we have been from units that have been donated.
That's true. There was a question here, yes.
Yes. What is if you don't have a perfect match, what is the overall fatality rate with bone marrow transplant? Because it seems like with gene therapy, the cancer is pretty treatable. And even over a lifetime, the 10 to 15% risk, but cancer is fairly treatable. It seems like gene therapy may be lower risk overall.
It's hard to say. So right now, the overall survival rate of allotransplant in this country is actually very good, especially for boys with ALD, because boys with ALD don't come in with a lot of the other exposures that children getting transplanted for leukemia have. So they haven't gotten chemotherapy before. So I think if you look nationally about all comers, they say about a 10% chance of dying in the first 100 days. However, that's not for boys with ALD. And so for boys with ALD, actually it's hard to get that data specific, but it is very low. So that acute sort of risk of dying is, I think, less than 5%, especially at centers that do a lot. Over a lifetime, a 5% to 10% chance of a cancer, it sounds very high, it's still relatively small if you include all cancers that people may get naturally. And it's hard because the gene therapy right now, we're still learning a lot about it. So, one boy did die, and we've had a child who had their disease come back and have to get a second transplant, and it's not an easy process. And so I think it really depends on sort of the lens you look at as an individual and a family for what risks matter more. And as someone who has treated many of the patients on the gene therapy studies, and I personally treated some of the boys who've had cancer, we both have, I will say I don't think we're done with cases. I think that there will be more cases over time. So we are 10 out of 67 now. We don't know if and when that's going to stop. So I just want to be fully transparent about that.
Right, and awareness is the most important
Yes.
element and close follow-up. So the sooner we find out things, the sooner we can follow these patients and then move to the next step of treatment is the most important thing.
Yes, Miranda.
There's a question in the chat. If someone's interested in getting more of a formal education to volunteer and spread awareness about the ability to bank in a public bank, is there an organization or somewhere that you recommend they reach out to?
Yeah, we can send you the information, yes. There's the government site has information, HRSA has information.
Okay.
Yes.
And the National Marrow Donor Program.
Right, the same.
Same thing, they have a lot of information. We can get that to you, Miranda, afterwards. I know that there's a volunteer to give the information about Viacord and the Sibling Connection Program. We can also share all of that information in one spot for people. I know you have my email. You could also share email with anyone who wants it.
I had a couple questions.
Oh, yes.
You'd mentioned with cord blood that there is, one of the drawbacks is that there's less cell mass. I'd heard of families having a double cord blood transplant. Is that something that's still being done?
Good question.
And my second question is for allotransplant. I believe some centers now are employing T-cell depletion as a preventative measure. I wonder if you could talk a little bit about that as well.
Absolutely.
Right, so let's start with the T-cell depletion first. Most of the centers are not doing it anymore. The reason T-cell depletion was done to prevent graft versus host disease. So if they're not 100% matched, or even if they're unrelated, so there is a chance of other mismatches, we would take out the T-cells to make sure the GVHD is not severe. But we have ways now that we can do this without taking the T cells out, so we give medications after the transplant. Therefore, and that's why most of the haplotransplants are being done like that. It's a method called post-transplant cyclophosphamide. It's a drug that we give that attacks the donor T cells early on, so they don't cause GVHD, and eventually the immune system recovers. So that's one. Double cord. Double cord is a transplant aspect or a transplant method we use mostly for adults and for leukemia patients. The patients we're talking about here are usually young. So the reason to do two cords is because we don't have enough cell dose in one. There are two things that have changed in the process of the years. One is that our cord blood banks bank bigger and bigger units because everybody now realizes how important it is to have most of the cells that we can. So what the units we find in the registry, in the banks, are bigger. One, and two, because of our patients' weight is not exuberant, most of the times we can do a transplant with one cord blood unit. That has some advantages in terms of graft versus host disease and complications. So most of the transplants that I know of that have been done in metabolic diseases are with single unit cords.
And maybe just one last thing, just to add. I think We definitely, there are risks and benefits to both of them. And I've had people ask, like, why are we even doing gene therapy now when this risk exists? And there are children, you can do a half match, you can do a cord, you can do those things. And I was once at a NORA, National Organization of Rare Disease meeting, and someone said, and I really believe this, that choice is a luxury in rare disease, and I really think that having choice matters. And on a personal side of things, I have 4 boys myself, 3 of whom are not biologically related to me, and they are mixed race, and which makes it really hard to find in a registry. And I like to think that if my children ever needed a transplant, it's terrifying. I don't think that they would have a donor in the registry. We need to have an option available for every child. So my boys don't have ALD, but if they did, I would want them to have every option. And there's a lot of effort being put into improving the safety of gene therapy, trying to move things forward. So while we talk about all the things that can go wrong in this, a lot of stuff can go right. And we saw that for Dr. Fatimi's talk this morning. These therapies work to control disease if we catch boys early, which is why newborn screening has been so extraordinarily momentous for the disease. So we don't want to leave you down with all the things that go wrong, because there's a lot that can go right, and the expectation is that it will. Thank you.